Greetings to everyone. I am Dr. Abhishek Nagarajappa. I will try to give a brief glimpse on predictors of post spinal hypertension and their current evidence in literature. We have a good understanding of mechanism of hypotension after spinal anesthesia. Spinal anesthesia causes sympathetic blockade, leading to decreased venous return, cardiac output, and systemic vascular resistance. There is usually a pre-procedure hypovolemia, either due to altered physiological state, such as in elderly, or pre-procedure fasting, or even hemorrhage during emergency. There could also be other intrinsic diseases of the heart which may predispose the patients to post-spinal hypertension, but that is beyond the scope of this talk. All the techniques used to prevent post-spinal hypertension targets these known areas, such as IV fluid loading, use of vasopressors, selection of appropriate dose and volume of local anesthetic drug, etc. So it is obvious we have to target these areas to identify predictors of post-spinal hypertension. Medical literature is filled with numerous studies and articles trying to identify definite predictors of post-spinal hypertension. Here I have compiled those that are available in literature. I will address these one at a time. The first and simplest known predictor is age and sex. Elderly population has the highest risk of developing hypertension. Elderly women are more prone than men. In pregnancy, the incidence is as high as 71%. Isobaric local anesthetic drug and higher total dosage were independently associated with increased incidence of hypertension. Preoperative baseline heart rate has been shown to be a good predictor for post-spinal hypertension. A baseline heart rate of below 92 beats per minute is probably low risk. However, patients with heart rate of more than 92 are high risk for developing post-spinal hypertension. If you observe this ECG closely, you can appreciate there is variability in the heart rate depending upon patient's respiration. Heart rate variability is another good predictor. However, this is not a bedside test and requires pre-op Holter monitoring and analysis or an advanced cardiac monitor to determine the heart rate variability index. And finally, we have ultrasonography, an excellent tool, extremely powerful in experienced hands. Till now, numerous techniques have been developed, debated upon, discarded, reutilized, and new techniques are being researched upon. Some of the views used to predict hypertension are as follows. IVC diameter and collapsibility index, probably the most commonly used technique to assess patients' volume status. With the help of focus-assessed Transthoracic Echocardiography, also known as FATE, left ventricular end diastolic area and diameter can be measured, another simple technique to measure volume status. Other more advanced techniques include velocity time integral, carotid peak systolic velocity variations, and femoral vein measurements. I will describe IVC collapsibility in detail, starting with the procedure. Have the patient lying in supine position. Ergonomics is very important. Face the patient. Have the ultrasound monitor directly in the front facing you. Probe selection, we can either use curvilinear low frequency probe or cardiac phase array probe. Place the probe under the xiphisternum with the axis of beam in parallel to the long axis of inferior venacava and the orientation marker pointing towards the chin of the patient. Select appropriate depth to keep IVC in the center of the screen. We may have to toggle the probe to look inside the thoracic cavity to visualize IVC along with right atrium. Say I have cut the probe under the xiphisternum. Immediately underneath is the liver. Heart lies cranially. Right atrium is continuous with the inferior vena cava lying immediately right from the midline and aorta on the left. Orient the probe in the long axis of the IVC with marker facing the chin. Slide the probe gently towards the right side to identify inferior vena cava. In this video, we can clearly see all the structures. Measure IVC diameter at the level of hepatic vein or around 2 to 3 centimeters away from right atrium. By selecting M mode, the maximum and minimum diameters during end expiration and end inspiration are measured. Sniffing can be used to measure the minimum diameter. This is a live demonstration in my OT. Orientation marker is towards the patient's chin. Identify the xiphisternum. Place the probe just below it. Now the ultrasound probe in between aorta and inferior vena cava. I'm going to slide the probe slowly towards patient's right side until we can visualize the inferior vena cava draining into the right atrium. We can also appreciate hepatic vein draining into the IVC through the liver. Have a look at the current probe orientation, which is angulated towards base of the thoracic cavity. For every patient, this angulation may be different. By doing this angulation, ultrasound beams strikes perpendicular to the vessel, giving better resolution and higher definition. At times, IVC may not be visible at all or completely collapsed. Ask the patient to flex his knee. IVC will be more readily visible within the next few seconds, like this. To measure IVC diameters accurately, activate M mode. Look for changes in diameter, fluctuations with respiration. Normally, with each inspiration, diameter decreases, and with each expiration, diameter increases. Freeze the screen and measure both the diameters using inbuilt calipers. Note the measurements to calculate IVC collapsibility index. One may commonly get confused between aorta and IVC. To differentiate, IVC lies directly under the liver attached to it. Hepatic vein drains into it and IVC in turn drains into the right atrium. On the other hand, aorta lies further below the liver with other tissues present in between, is more pulsatile and does not drain into the right atrium. The measured maximum and minimum diameters can be used in this formula to calculate IVC collapsibility index, which normally ranges between 20 to 50%. Value greater than 50% indicate a volume deficit patient, a potential candidate for post spinal hypotension. There are plethora of studies which support its use to predict post spinal hypotension, and many who did not get similar use. This article from Canadian Journal went on to say it is easy, fun, but unlikely to be helpful. From my institute, AIMS New Delhi, we have published two studies. Both the times, inferior vena cava collapsibility index was not found to be useful. Focus assessed transthoracic echocardiography is a protocol for rapid assessment of cardiovascular function. For diagnosis of hypovolemia, there are four independent criteria: left ventricular end diastolic diameter, end diastolic area, end diastolic area index, and systolic obliteration of left ventricular cavity. It is obtained by four standard views: parasternal long axis, short axis, apical, and subcostal views. It would be ideal to use cardiac phased array probe for FATE protocol. If that is not available, a low frequency curvilinear probe can be used with certain limitations. In parasternal long axis view, patient is placed in left lateral position, and here the orientation marker of the probe is towards patient's right shoulder. Here we look directly into the heart in its longitudinal axis. Parasternal short axis view is obtained by turning the probe 90 degrees so that the orientation marker is now facing patient's left shoulder. Here the plan is to visualize at multiple levels: at aorta, mitral valve apparatus, and left ventricular apex in short axis. Apical view is achieved with patient in supine position with left lateral tilt to look into the heart through the ventricles. And finally, subcostal view is achieved with patient in supine position with both legs fixed at knees, abdomen relaxed to look right through the right ventricle. In this parasternal short axis view, we are measuring left ventricular end diastolic diameter and left ventricular end diastolic area. No single parameter is gold standard. A combined approach using multiple parameters has higher success than any individual parameter. This is a recent article from BMC Anesthesiology. They concluded that heart rate and left ventricular end diastolic area combined with velocity time integral percentage may predict spinal anesthesia induced hypotension more precisely than single parameter. To conclude, I would say use your ultrasound machines to their full potential. No single technique is the ultimate answer. There is a lot of scope for research. Try the old ones, make new ones, keep searching for that holy grail to prevent hypotension and promote safer anesthesia practices. Thank you so much for patient listening.